All right, good afternoon. We are going to get started as soon as we have the slides on. Welcome to Educational Session 8. My name is Antonio Wolff. I am a professor of oncology at Johns Hopkins and interim director of women's malignancies there. I have a wonderful panel with us today. Doctors Heather McArthur, Erica Mayer, and Doug Johnson, and Ms. Sheila Johnson, who is an advocate. She's going to be part of the panel. So Educational Session 8 on toxicity management and next generation therapies imply next generation toxicities. These are my disclosures. I have only one slide to help us set the tone for this session. As you guys will see, a lot of the things we're discussing today during the presentations will focus on old but also new toxicities as we learn how to use these new drugs that are here to stay. But I think we want to be fair to all in the audience, especially advocates, in preempting question number one that may come. If we only focus on drug toxicities, people are going to say, what about everything else? So there are the toxicities we measure, the toxicities that we don't know how to measure, or we don't measure well, or sometimes we ignore and don't pay attention to them. For patients with early stage disease, we think we need to remember that the majority of men and women diagnosed with breast cancer today with early stage disease will be cured from their disease, and they will move on with the rest of their lives. So our job is to be careful that they don't live with the consequences of our best intentions. And it is so easy sometimes to do more just in case because we are concerned about leaving potential benefits on the table. There is a critical need for therapy optimization, and more and longer may not be better. We don't have biomarkers for a lot of the treatments we give to identify who needs more or less or may not need the treatments we want to give them. And for patients with advanced disease, remember that quality of life sometimes is sacrificed in the search for quantity of life. There is no question. We are talking about allowing patients to live longer who have advanced disease, but we want to make sure that they live well. And I think we owe to patients to help them define what is considered a meaningful life. It is not for us to define, it is for them to define. We need to help them. The challenge is that a lot of this requires long conversations, and we are often limited in time to do that. Sometimes we don't have the ability to have staff with us. It is not often reimbursed based on the reimbursement models we have, at least in the US. And equally important, we are talking about drug toxicities, but remember, time toxicities, time away from home, from work, from loved ones, financial toxicity, and the impact on caregivers and families. So it is in that context that I want you guys to think about the presentations you're going to hear over the next several minutes. And then at the end, I'm going to ask Ms. Johnson to share with us a couple of her thoughts as well. We want to hear from you, so please come to the microphone during the Q&A, introduce yourselves, and let's try to make this as dynamic as we can. So to get the ball rolling, the first presentation is going to be on antibody drug conjugates to be given by Dr. Heather McArthur. She's an associate professor in the Department of Internal Medicine and clinical director of the breast cancer program at the Simons Cancer Center at UT Southwestern. Heather.
Thank you, Dr. Wolff, for that kind introduction. And thank you to the committee members for including me in this terrific program. Really excited to see what discussions arise today. Just waiting for slides. There we go. So I'm going to talk about toxicity management as it pertains to antibody drug conjugates, which is obviously an exciting new area of therapeutic innovation for us. These are my disclosures. So why pursue antibody drug conjugates? So there are a number of limitations of chemotherapy. As we know, chemotherapy inhibits cell proliferation through the disruption of cell cycle at different phases that leads to anti-cancer activity, but it also damages healthy cells that have high replication rates. And hair follicles, gut epithelium, and bone marrow are particularly susceptible. So could a targeted delivery improve the tolerability of chemotherapy? So just to review some principles of antibody drug conjugates, the primary purpose of these drugs is to achieve targeted delivery of the payload by only delivering them to tumor cells and not to healthy cells, and tumor cells that specifically express the antigen that's targeted. That would allow for sensitive discrimination between cancer cells and healthy cells. It would widen the therapeutic window potentially. It would minimize systemic drug distribution. It would reduce chemo-related toxicity potentially, and delivery of potent agents would potentially be possible because you're targeting those potent agents directly to the tumor cells and not to healthy cells. However, unfortunately, with the first generation of antibody drug conjugates, non-internalizing drugs did not increase drug selectivity and thus did not reduce toxicity. So the recent successes that we've seen in this really unprecedented era of rapid drug development has been largely due to linker and conjugation technology. So just to remind us all of the anatomy of an antibody drug conjugate, so there has to be a target antigen to which the antibody is directed. The antibody, of course, provides the guidance for the drugs. The antibody is linked through a linker molecule to a cytotoxic drug, which is the warhead or the payload for destroying cancer cells. And this is not a particularly novel idea. It's actually an idea that dates back almost exactly 100 years now, when Paul Ehrlich first had the idea that you could link drugs to antibodies. Sorry, it sort of has a mind of its own. But it took until recent years that this technology actually became feasible in the clinic. And actually TDM1, a drug that we're all familiar with, was the first antibody drug conjugate that was approved by the FDA for the treatment of solid tumor. So breast cancer, we were there first. And in recent years, we've had a number of additional approvals by the FDA. TDM1's been approved in expanded access. TDXD has been approved for HER2-positive and HER2-low breast cancer. And sacituzumab govitecan has also been approved for metastatic triple-negative breast cancer and hormone receptor-positive breast cancer. So it's been an unprecedented era of drug development. But are they truly targeting, or are they truly precise in their targeting? So it's worth noting, and I highlight some of the drugs here. I'm sorry, it does have a mind of its own. The rate of any grade treatment-related adverse events is more than 90% with all of the antibody drug conjugates that are approved. That's an unbelievably high number of adverse events. So yes, there is some precision, but we haven't yet perfected the technology. And worth noting that there are hundreds of drugs that have been evaluated in clinical trials. Some of them, as you know, have been successful, but a number of them have been discontinued for a variety of reasons, including narrow therapeutic index, as well as toxicity issues that have not permitted further drug development. So there's still a lot of work to do in terms of perfecting this technology. But we have had some recent successes with drugs that I show here. Dato-DXd, sacituzumab, trastuzumab, deruxtecan are the drugs that I'm going to talk about today. Sorry, I don't know why it's advancing independently. Or going back independently now. Sorry about that. Due to differences at the molecular level, each antibody drug conjugate has its own safety profile, and I'm going to focus primarily on the drugs that are currently approved, as well as one drug who is that's imminently expected to be approved as it's being developed in clinical trials. So early antibody drug conjugates like TDM1, again, the first drug that was developed in this with this technology, it has non-cleavable linker, which is important. unique feature because the modern antibody drug conjugates do have cleavable linkers and low membrane permeability. And this results in target cell intracellular payload release and toxicity. So TDM1, it is more potent than paclitaxel, 400-fold more potent, and this antibody drug conjugate allows for higher dose of cytotoxic drug to be delivered. So a higher drug to antibody ratio means higher amount of drug potentially being delivered to the cell of interest. Again, TDM1 is a first-generation ADC, had a non-cleavable linker, and there are a number of studies that confirmed the position of TDM1 in the metastatic setting, including this one, which is Amelia. And we saw from the Amelia trial, for example, that there was less cytotoxicity, but there was more thrombocytopenia and liver enzyme derangement with TDM1 when compared to chemotherapy with targeted therapy. We've also seen in the curative intent setting in the Catherine study where patients were randomized to receive trastuzumab, the standard of care, to complete a year, or TDM1, not only improvement in efficacy that led to a survival advantage, but we saw the same toxicity issues, decreased platelet count, fatigue, and neuropathy, which we all know in patients who have already received a taxane, additional neuropathy risk is undesirable. So why are we seeing this toxicity? Well, it's common to the drug from which it's derived, maytansine. Maytansine has peripheral neuropathy, nausea, diarrhea, fatigue, hepatotoxicity, and the toxicities that we've seen in the metastatic and curative intent TDM1 studies were very consistent with that. So again, speaking to the effect of potentially the payload and not the other technical innovations of the antibody drug conjugates. The targeting of antibody drug conjugates, so the antibody isn't always perfect as well, and we'll talk a little bit about why there's room for improvement with the antibodies. So TDM1, which targets HER2, and there's HER2 positive gastric cancer, was not effective in HER2 positive gastric cancer, nor was it effective in colorectal cancer or HER2 negative breast cancer. So it's obviously more than just about the target and the antibody. It's about the whole combination, the antibody, the linker, as well as the payload. And so there's room for improvement, and we have seen those improvements in the form of TDXD, which is also a HER2-directed antibody that's linked to a payload. In this case, it's a topo-1 inhibitor, whereas with TDM1, it was an antimicrotubule agent. It has a higher drug to antibody ratio, so more drug potentially getting to the cells of interest. It has a cleavable linker, which again, TDM1 did not, and there is thus the evidence potentially of a bystander effect that's allowed with this cleavable linker. We've seen data from multiple studies looking at trastuzumab deruxtecan, including the first study that was DESTINY-Breast01 with this impressive waterfall plot in heavily pretreated population that led to a new standard of care. But we also saw some real-world toxicity in the form of nausea, fatigue, alopecia, and vomiting. Another toxicity concern that arose was this issue of interstitial lung disease. There were 5 cases, so 2.7% incidence of interstitial lung disease that was fatal on the first DESTINY-Breast01 trial. So obviously that was a huge cause for concern, and on subsequent trials there was more conservative monitoring. The toxicity with the interstitial lung disease seems to be within the first 12 months. Once patients get past that 12-month mark, there don't seem to be cumulative new cases of ILD. And then we got more experience in monitoring for ILD with the DESTINY-Breast03 study. This is a study where they looked at TDXD versus TDM1, which was the standard of care at that time. And Q6 weekly monitoring for ILD was adopted for that study, so much more frequent than what we would normally do in our routine clinical practice. They still had the same issues as we'd seen in DESTINY-Breast01 with the nausea, the vomiting, the fatigue, and alopecia. So there weren't significant inroads there, even though there was heightened awareness around those potential toxicity issues from DESTINY-Breast01. And it's worth noting that the time to onset for the nausea and vomiting was almost immediate. And once it occurs, it persists. So it's not one of those manifestations that if you get it under control, it goes away after a couple of months. The prevalence of the nausea and vomiting persists throughout the treatment duration. So that's an interesting and kind of novel pattern for us. So there are prescribing recommendations and there are NCCN guidelines around this issue of nausea. By NCCN, TDXD is classified as a highly emetogenic agent, and as such, a 4-drug regimen as prophylaxis is preferred to be administered with this agent. We focus a lot on nausea and vomiting, but I think it's worth taking a moment to talk about the impact on fatigue and alopecia as well. The fatigue observed with this drug is also almost immediate, as is the alopecia. Fatigue is, of course, a difficult toxicity manifestation to monitor or to manage. With the ILD in DESTINY-Breast03, fortunately, with that improved or more conservative monitoring schedule of every 6 weeks, there were fortunately no fatal events of interstitial lung disease, although it was a potential burden to patients to get that frequency of monitoring. And then we saw DESTINY-Breast04, which was a study looking at this same drug, trastuzumab deruxtecan, and HER2-low disease, which became a new standard of care in that setting as well. Even with all of that cumulative experience that I've just shown you with DESTINY-Breast1, 2, and 3, we still saw considerable incidence of nausea, fatigue, alopecia, and vomiting with this regimen. Fortunately, most of that was lower grade than what we'd seen on previous trials, but it still cumulatively was a problem, particularly the nausea and the vomiting. In the DESTINY-Breast04 study, in looking at the interstitial lung disease events, there were unfortunately 3 fatal interstitial lung disease events, again, despite the heightened awareness and the more frequent scans to identify early problems. It's worth noting that the median time to ILD and pneumonitis on this study was 129 days, but worth noting the huge range around that number, 26 days to 710 days. So continuous vigilance is really critical when administering this drug. There have been some attempts to provide guidance around ILD management and surveillance. So at the present time, high-resolution CT scans are recommended at least every 12 weeks, and even more frequently every 6 to 9 weeks in patients who have respiratory symptoms. If ILD is suspected, you need to hold the drug and intervene. You should consider corticosteroid treatment as soon as ILD or pneumonitis is suspected, and if clinically indicated, consider PFTs, ABGs, and pulmonary consultation. If a patient has grade 2 or more disease, then the drug needs to be permanently discontinued. So grade 1 disease, just as a reminder, is asymptomatic, radiographic only disease, which is why those shortened intervals on the later DESTINY-Breast trials were so important, because they did the CT scans, they did the imaging much more frequently than they had in that first effort. And that's because if you find grade 1 ILD, you could intervene and potentially re-challenge, which is what we'll talk about in a second. But if they get grade 2 disease, you must permanently discontinue this drug. There's some guidance around days and how to think about resolution of interstitial lung disease if a patient has grade 1 disease. So this is, again, if you're thinking about a potential re-challenge for your patient. If it's resolved less than 28 days from the date of onset, you can reinitiate drug, but at the same dose. So that would be the 5.4 milligrams per kilogram. If it takes longer to resolve, more than 28 days from onset, then you should dose reduce. And here are the reduction levels. The first reduction is to 4.4 milligrams per kilogram, and the second dose reduction, if you need it, is 3.2 milligrams per kilogram. If it occurs beyond 22 days, but within 49 days, some have advocated to discontinue TDXD permanently. And it should only be restarted following a confirmed and resolved to grade 0 case of grade 1 ILD pneumonitis. So again, any symptoms require permanent discontinuation. Grade 1 that's managed effectively and reduced to grade 0 within this time frame as outlined can potentially be rechallenged. And in fact, in Destiny Breast 04, there were 6 patients who had grade 1 ILD or pneumonitis who were rechallenged with TDXD after resolution of their radiographic signs. 5 of them were successfully rechallenged. 1 of them developed a second episode of interstitial lung disease. Grade 2 was the adjudicated designation for that second event, but 5 were successfully rechallenged. Now we're going to switch gears from HER2-directed antibody-drug conjugates to TROP2-directed antibody-drug conjugates. As you'll recall, sacituzumab govitecan is a highly selective antibody-drug conjugate that's directed to the TROP2 antigen. It has a high drug-to-antibody ratio, 7.6 to 1. It is internalized and enzymatically cleaved by the tumor cell, but it's not required by the tumor cell, for liberation for the SN38, which is the toxic payload. So it can release drug into the microenvironment, so it doesn't require internalization for that linker to be cleaved. And so it can have this standby effect by direct exposure by extracellular linker cleavage. In the ASCENT study, we saw the effect of this TROP2-directed antibody-drug conjugate in triple-negative breast cancer, highly pretreated breast cancer that became a standard of care. And in TROPICS-02, we saw the impact of this antibody-drug conjugate in hormone receptor-positive breast cancer, or at least that's the population that drove the results of this study. The primary toxicity, so this had a very different profile than the HER2-directed antibody-drug conjugates. The most common drug-related adverse events were neutropenia, diarrhea, and nausea. So no interstitial lung disease with this drug, which is a common misconception that it's a class effect. It's not a class effect, so not reported with this drug. So the rates of neutropenia were 51%, which is a real-world management problem. Leukopenia, 10%, and diarrhea, 10%. Fortunately, neutropenia and diarrhea were manageable with dose modifications and concomitant medication support, with a low treatment discontinuation rate with sacituzumab govitecan that was very similar to the chemotherapy, less than 5%. And again, no interstitial lung disease with this drug. So again, we see that the toxicities of an antibody-drug conjugate, in this case sacituzumab govitecan, very much resemble the side effect profile of the chemo payload. So in this case, irinotecan also has the same profile of fatigue, nausea, vomiting, and diarrhea. So further innovation is necessary, and we've recently seen some data. This is not a drug that's currently FDA approved, but it's a novel TROP2-directed antibody-drug conjugate that's in development called Dato-DXd is the contracted form. It is a TROP2-directed antibody-drug conjugate like sacituzumab govitecan. It has a topo-1 payload inhibitor. It has a drug-antibody ratio of 4, so less than the sacituzumab govitecan, and it has a long half-life. We just saw a few weeks ago the results of the TROPION-01 study. This is a study that was looking at this antibody-drug conjugate, Dato-DXd, versus chemotherapy in a pre-treated population, and that was presented by Dr. Bardia. And here you can see those impressive results here in terms of progression-free survival. The overall survival data is not yet mature and has not been presented. But there were some interesting toxicity issues that arose from this presentation. So fortunately, most of the treatment-related adverse events on this study were grade 1 or 2 and very manageable. There were, however, some adverse events of special interest, namely oral mucositis or stomatitis. So 59% of patients had some form of mucositis or stomatitis. Fortunately, only 7% were grade 3, but it did lead to a treatment discontinuation in 1 patient. I've listed here the laundry list of all of the potential clinical manifestations that could come under this heading of oral mucositis and stomatitis, and this is one of the challenges that we face. The CTCAE has a lot of different potential entries, and you can potentially miss things if people categorize things differently. And here's the many different ways that a mucositis or stomatitis issue might be categorized. So when this drug is being administered, prophylactic dexamethasone mouthwash is recommended. You need to continue to use the mouthwash throughout the duration of your exposure to the treatment. And cryotherapy, which I do a different kind of cryotherapy research, but cryotherapy here means ice chips, can also be extremely helpful in managing this side effect with this drug. It was also interesting to see that there was a novel toxicity issue with this drug. There were ocular events. So on this study, ophthalmologic assessments were required at screening, and then they were done every 3 cycles, starting from cycle 1, day 1, and then at the end of therapy. Most of the reported ocular toxicity was dry eyes. 49% of patients experienced some ocular toxicity, but fortunately only 1% had grade 3 toxicity. But you can see of those 3 patients that had grade 3 toxicity, they were quite divergent in their presentation. One was simply dry eye, one was punctate keratitis, and one was dry eye with ulcerative keratitis. So close ophthalmologic monitoring is critical with this drug, and did in fact lead to a drug discontinuation in 1 patient on this study. Back to the issue of interstitial lung disease. Fortunately, on this study, the rate of ILD was low, and it was mostly grade 1 and grade 2. There was 1 drug-related grade 5, so fatal interstitial lung disease event, but the investigator ultimately deemed that it was related to progression of disease. Here are the results of the Begonia study, the arm 7 from this sort of octopus study. In this arm, the drug that we've just been talking about, Dato-DXd, was co-administered with checkpoint blockade immune therapy in the form of durvalumab. This study was just updated at the recent ESMO meeting, and a confirmed overall response rate of 79% in the first-line metastatic triple-negative breast cancer population was reported. So this is, in my mind at least, an unprecedented response rate in a typically very high-risk population. And so you can imagine that these combinations are moving forward, which incurs some additional toxicity discussions beyond just talking about antibody-drug conjugate toxicity. The most common adverse events seen on this study were gastrointestinal and generally of low grade. Not surprisingly, and consistent with the Tropiano-1 study that we just talked about, stomatitis was most common. And there were a few interstitial lung disease, 2 grade 2 events and 1 grade 1 event. And the dry eyes persisted in this study as well. And the reason why I bring this up is because there are studies that are ongoing right now that are looking at moving these same strategies into the curative intent setting. So there are studies that are open to enrollment for patients who have early stage triple-negative breast cancer, who receive their standard of care chemotherapy, potentially with immune therapy in the neoadjuvant setting, and don't achieve what we call a complete response. And they are being randomized on clinical trials to receive continued standard of care in the form of pembrolizumab to complete 1 year versus immune therapy together with an antibody-drug conjugate, given how promising this antibody-drug conjugate data has been, particularly in combination with checkpoint blockade. So this is the optimized residual disease study that's being led by Sarah Talani through the Alliance Cooperative Group. Patients are being randomized if they have residual disease to receive continued pembrolizumab versus the TROP2-directed antibody-drug conjugate sacituzumab govitecan together with pembrolizumab, and that effort is underway. Then there's the Tropian-Breast-03 study. This is a study that actually has 3 arms, again enrolling patients with residual triple-negative breast cancer after neoadjuvant therapy and randomizing them to receive Dato-DXd, so another TROP2-directed antibody-drug conjugate, together with durvalumab versus Dato-DXd alone versus the standard of care. And that study is open and being run in partnership with the SWOG Cooperative Group and is actively enrolling. And then recently we opened the Tropian Breast 04 study. This is a study looking at Dato-DXd together with durvalumab in the neoadjuvant setting. So the only neoadjuvant antibody drug conjugate study that I'm aware of, together with durvalumab, going head-to-head against the Keynote 522 regimen with the hope of mitigating a lot of the chemo-induced toxicity, but hopefully also improving efficacy. And that study just recently opened globally to enrollment. So I'm going to end up here by talking about some determinants of antibody drug conjugate toxicity. There are a number of contributors to potential toxicity. There is the linker stability, there's the type of payload, there's the antibody and the target, as well as patient-specific characteristics. No antibody drug conjugate linker is fully stable, however, and more unstable linkers lead to more chemotherapy-related side effects. So there's work to be done there. Antibody-related toxicities are common, but rarely limit the tolerable dose of the antibody drug conjugate. Examples are, for example, trastuzumab deruxtecan, which is trastuzumab, as the antibody there, which we all know causes reversible cardiotoxicity for the most part, but it's extremely well tolerated. Payload-related toxicities generally determine the maximum tolerated dose. And as we've seen here, the payload of the antibody drug conjugates very much mimic the drugs from which they are derived. And there are opportunities to optimize not just the efficacy, but the toxicity profile of these drugs through various modifications. We can either dose optimize these drugs, either with fixed dose or shorter duration of dose. There's drug engineering that's possible. There are pharmacogenomic insights to be had, and I'll give you an example of one of those in a second, as well as diagnostic tools. So here's an example of a potential pharmacogenomic insight. So on studies where patients were treated with sacituzumab govitecan, the enzyme UGT1A1 metabolizes the SN38 payload, which again is a derivative of irinotecan. And among patients enrolled in a basket trial, about 28% had an increase in the most side effects, more than double the risk of severe anemia and neutropenia, begging the question, should we be testing these patients? And this is very hypothesis generating. I'm not advocating for doing this on Monday morning, but it suggests that we don't all process these drugs differently, and there are individual differences and maybe some racial differences that need to be interrogated. So more work needs to be done in this space. Then there are a lot of tools that we could be employing to better monitor for toxicity. There are wearable devices that can obtain continuous monitoring of vital signs that could be associated with interstitial lung disease, for example. So there are a lot of modern technology tools that we could be providing to our patients that would help us identify problems early on. Again, with the trastuzumab deruxtecan, once a patient has symptoms, they have to be taken off the drug forever. And so early identification of those grade 1 patients is critically important. And are these types of tools helpful for patients at home to help identify those patients early on? So here are the take-home messages. That advances in antibody drug conjugates have led to meaningful prognostic improvements in the field. It's certainly been a fast-paced drug development era in recent years. And despite being more active than prior generations, the current generation of ADCs has been more toxic with higher incidence of chemo-related side effects, however. So optimizing the toxicity of antibody drug conjugates starts from identifying the dose and schedule that maximize the risk-benefit ratio. And pharmacogenomic testing may identify patients who are more vulnerable to specific side effects than others. Molecular innovations in each antibody drug conjugate are being pursued to deliver a new generation of ADCs that are more tolerable and closer to the magic bullet that was envisioned by Ehrlich a century ago, remarkably a century ago. So with that, I'll conclude. I'd like to thank you. We had a special fellows forum on Monday that was really terrific. I just wanted to highlight some of the abstracts that are being presented on the Thursday evening poster session by fellows I highlighted two here. The first was by a fellow from the program. The other one was not in the program, but I thought it was interesting looking at toxicity with sacituzumab in Arab patients specifically. And I'd like to thank my friends and colleagues, Paulo Tarantino and Aditya Bardia, for their input. Thank you.
Thank you very much, Dr. McArthur. We're going to have time for questions during the panel discussion, and next to speak to us will be Dr. Erica Mayer. Dr. Mayer is an associate professor in medicine at Harvard Medical School, and she's also director of breast cancer clinical research at the Dana-Farber, and she's going to talk about next-generation therapeutics in hormone-positive breast cancer, balancing efficacy and tolerability. Dr. Mayer.
Thank you very much. Hi, everybody. Thanks so much for coming to our session today. My disclosures. So as we consider the spectrum of agents available to us to treat hormone receptor positive breast cancer, I think it's really important to think about how we achieve the right therapeutic balance. So we want to think about risks and benefits. We are so fortunate to have exciting new targeted therapies for hormone receptor positive disease. These are often given in combination with an endocrine backbone. This includes inhibitors of CDK4/6, PI3 kinase, AKT, mTOR, and the new oral SERDs. And these agents are approved or in study in the advanced setting and increasingly approved or in study in the early stage setting. And I think we'd all agree that with the use of these agents, this has led to definite positive improvements in outcomes for hormone receptor positive disease. However, all therapies come with a toxicity cost, as we just heard from Heather. This can impact dose intensity, adherence, limit overall use. But it does provide some opportunities for us to think about how to manage toxicity with prophylaxis, symptom management, or even novel dosing strategies. So my job in the next 25 minutes is to review these new therapies and to think not only about the toxicity spectrum that we have learned about, but also think together about some of the strategies we can use to mitigate toxicities. So first, we're going to turn to CDK4/6 inhibitors. As we know, there are 3 available agents, palbociclib, ribociclib, and abemaciclib, which have been extensively studied in the metastatic setting. And through these 7 large randomized trials, we have them approved in the pretreated and first-line settings. And I think we've all been struck by how remarkably they improve progression-free survival across the board. But we also recognize that these are not all the same agents, and we get a clue about this from the differentiated toxicity profile. Palbociclib and ribociclib are more likely to cause asymptomatic neutropenia, not associated with febrile neutropenia or infectious complications, but something that can frequently be seen. This is less common with abemaciclib, although abemaciclib is more likely to cause diarrhea. Ribociclib is associated with QT prolongation and LFT abnormalities, and it's important when patients are beginning these therapies that we carefully monitor them, as listed on this slide, especially in the first 2 months of treatment, and use dose modifications if necessary. Less common toxicities include venous thromboembolic disease and interstitial lung disease. Now, sometimes we might be hesitant about using dose modifications. We might be worried, are we going to lose efficacy if we reduce dose? This has been looked at for CDK4/6 inhibitors, and reassuringly, we find that dose reductions do not impact efficacy in the metastatic breast cancer setting. And we see examples here on the slide of the impact of dose reductions with abemaciclib and with ribociclib with preserved progression-free survival. Now, these agents have also entered the adjuvant setting. There have been 4 large randomized trials, including PALLAS and Penelope-B, which looked at palbociclib, Monarch-E, which looked at abemaciclib, and NATALEE, which looked at ribociclib. And both Monarch-E and NATALEE have demonstrated that the addition of the CDK4/6 inhibitor improved invasive disease-free survival. Monarch-E looked at a 2-year duration of adjuvant abemaciclib added to ongoing adjuvant endocrine therapy versus endocrine therapy alone, whereas the NATALEE trial looked at a 3-year duration of ribociclib added to endocrine therapy versus endocrine therapy alone. It is important to note that the dose of ribociclib used in NATALEE was lower than that which is approved in the metastatic setting, using 400 milligrams instead of 600 milligrams in an effort to make the drug more tolerable for the planned 3-year course. As we'll see in the following slides, the Monarch-E trial is a little bit more mature, so we have more understanding of the side effect profile. We are still learning about NATALEE, and I think we all are looking forward to the updated analysis, which will be presented here later this week. So in Monarch-E, the side effect profile seen from the addition of abemaciclib was very similar in the early stage setting to what we see in the advanced setting. Diarrhea was a common side effect. This occurred in over 80% of patients, although only a fraction of those patients had grade 3 diarrhea. Other prominent toxicities included cytopenias like neutropenia and fatigue as well. There were the rare toxicities of special interest. This included venous thromboembolic disease, which was slightly increased with abemaciclib. For this reason, we try to avoid giving abemaciclib with concurrent tamoxifen, as both of those agents have the risk of VTE. Additionally, we do see a slight increase in interstitial lung disease, although quite different from what we just heard about with antibody drug conjugates. Now, in Monarch-E, 42% of patients required a dose reduction or dose modification, and you can see in this figure that the vast majority of these dose modifications occurred early on in treatment in the very first few months. 30% of patients in Monarch-E had to discontinue abemaciclib early. Of those, 18% were due to adverse events. Most of this was also in the first 6 months of therapy, so that's a more tender and vulnerable time when a patient is starting treatment. Importantly, though, of those who discontinued for adverse events, over half did not have a prior dose reduction. So that's a missed opportunity where perhaps a dose reduction could have made it more tolerable and led to a place where the patient didn't have to discontinue therapy. The majority of dose reductions and dose holds were due to those primary toxicities of diarrhea, neutropenia, and fatigue. We've also seen some updated data looking at different subsets and clinical pathologic predictors of toxicity. If we're considering age, what has been shown quite reassuringly is that there does not appear to be a substantial difference in clinically relevant adverse events in patients who are younger, meaning less than 65, versus older, 65 and older, and this includes for diarrhea, fatigue, and neutropenia. Despite this reassurance, we have seen that patients who are older do have more dose reductions. And if you look at the top, you will see that the patients who are older than 65, a greater fraction had 1 or even 2 dose reductions while receiving abemaciclib. This was also seen similarly in patients with 4 or more comorbidities. And you can imagine there's a fair amount of overlap in those two populations. There's also been an analysis looking at factors which were associated with early discontinuation of abemaciclib, and again, age and comorbidity were primary factors. I think it's very interesting when you look at these curves that they separate very early, suggesting the majority of these discontinuations happen early, but the curves continue to separate over time. And so I think this means that we need to really be supporting and monitoring our patients early on in treatment when they're starting therapy, and continue to monitor and use dose adjustments as necessary to help retain patients on therapy. Now, we do know that dose reductions were associated with improved patient retention. We can see that patients who remained on abemaciclib for more than 6 months, of that group, a greater fraction had 1 or 2 dose reductions. So the use of dose reduction in this trial allowed patients to stay on therapy longer and helped with reducing discontinuations. And again, you might ask, well, am I losing efficacy by reducing the dose? Well, like we saw in the metastatic setting, there has also been an analysis in the early stage setting with abemaciclib looking at relative dose intensity and outcome. In this analysis, relative dose intensity is divided into tertiles, 0 to 66%, 66 to 93, or greater than 93%. And as you look at the 4-year IDFS figures, you see that actually there's not really a big difference there. Patients who had a lower relative dose intensity were still gaining benefit from the addition of abemaciclib. So again, a piece of data that helps support the need to use dose modifications and reductions in clinic if necessary. There was a similar analysis in the PALACE trial, which was a trial that looked at a 2-year duration of adjuvant palbociclib added to endocrine therapy. In that trial, the rate of discontinuation was higher. 45% had to stop therapy early. The vast majority of discontinuations were due to neutropenia, which is a common side effect of palbociclib. And similarly, we saw that these discontinuations occurred early on, like what was seen in Monarch-E. A similar analysis was done looking at relative dose intensity, demonstrating that patients who had a dose intensity of 70% or greater or less than 70% did not have a substantial difference in their primary outcome of invasive disease-free survival. So outcome was not dependent on the relative dose intensity, again, reassuring. And finally, thinking forward to how can we make the experience of receiving abemaciclib easier for patients, we've recently launched a prospective phase 2 trial called TRADE, which is looking at a novel dose escalation scheme to help patients onboard onto adjuvant abemaciclib. Eligible patients initiate abemaciclib at a low dose, 50 milligrams twice a day for the first 2 weeks, then move up to 100 milligrams twice a day, and at cycle 2, day 1, they start the traditional dose of 150 milligrams twice a day. Primary endpoint of the study will be a composite adverse event rate looking at discontinuation and need for dose modifications. I don't put this up here to endorse doing this in your clinic. That's why we're studying it, but we're hoping to have data soon that will allow us to know if this is a helpful strategy. I'll also preview to say there will be a study launched by ASCO next year for older patients with metastatic hormone receptor positive breast cancer that will use a similar concept of a brief dose escalation of a CDK4/6 inhibitor to see if this makes the experience better and more tolerable for our older patients. So stay tuned for that. We also now have seen some early toxicity data from the NATALY study. Remember, this study used a lower dose of ribociclib than what we use in the metastatic setting. Reassuringly, we do see that the rates of neutropenia and QT prolongation appear to be lower in NATALY than what we would anticipate with ribociclib in the metastatic dosing. However, the rate of grade 3 LFT abnormalities was still 8%, not much different, suggesting that the lower dose helps with neutropenia and QT, but does not appear to help with the LFT abnormalities. And again, we need to wait for further data from this study to understand more. Now let's turn to novel endocrine therapies, and an exciting class of drugs is the novel oral SERDs. These are drugs that target the estrogen receptor, leading to degradation, and may be of particular interest in the setting of endocrine resistance. There are many advantages to oral SERDs, including that they're oral and that they are effective, but also they can be very well tolerated. This is a table listing the oral SERDs that are currently in development as well as other related agents. And you can see there are many studies going on in the metastatic setting. The agents have also moved into the neoadjuvant and adjuvant setting with large adjuvant trials which have launched. Those are indicated in red. In general, oral SERDs are thought to be well-tolerated drugs. These are some of the common side effects. This includes mild to moderate nausea, vomiting, and diarrhea. As well, there are some less common and somewhat more unusual toxicities with these agents. This includes asymptomatic grade 1 bradycardia, as well as visual disturbance called photopsia. Other adverse events include fatigue, hot flashes, and arthralgias. So let's review some of the data we've seen with oral SERDs. First, let's consider EMERALD, which was the registration study for the oral SERD elacestrant in pretreated patients randomized to elacestrant or treatment of provider choice. The population was older, in their 60s, the majority with visceral metastases, 20% with prior chemotherapy. In general, elacestrant was well tolerated. Most of the adverse events were grade 1 to 2. There were very few grade 3 or 4 events, and importantly, only 3.4% of patients receiving elacestrant had to discontinue early due to treatment-related effects. The GI toxicity in terms of nausea was fairly mild. Only a few patients had to use antiemetic drugs. So far this does appear to be a well-tolerated drug and is available in our clinics. Camizestrant was studied in the SERENA-2 study. This randomized pretreated patients to fulvestrant monotherapy versus different dose levels of camizestrant. Again, a population in their 60s, about half with visceral disease, about 20% with prior chemotherapy. And in general as well, camizestrant was well tolerated with few events of grade 3 toxicity. We did see these more unusual toxicities with camizestrant, including the photopsia and the asymptomatic bradycardia. And it's interesting to see that with increasing dose of camizestrant, we do see increasing rates of these toxicities. And for this reason, the lower dose of 75 milligrams has been selected to move forward in further studies. Imlunestrant data was recently presented in the EMBER study at ESMO this year. These were cohorts including monotherapy as well as combinations with everolimus and alpelisib. As monotherapy, imlunestrant was associated with low-grade GI toxicity, nausea, and diarrhea. The toxicity seen in the combination predominantly reflected the targeted partner, and we'll talk about those agents in just a moment. But there did not appear to be significant additive toxicity. And finally, giredestrant, looked at in the prospective Accelera study, randomizing patients to giredestrant versus provider choice endocrine therapy. Again, somewhat higher rates of GI toxicity, including hepatotoxicity, but mostly this was all grade 1-2, fatigue as well. There were low rates of bradycardia. Interestingly, in an earlier phase 1 study of giredestrant, the bradycardia was observed, and this led to creation of a cardiac sub-study, which enrolled 20 patients who were taking a somewhat higher dose of giredestrant, 100 milligrams. These patients had quite intensive cardiac monitoring. This included doing an exercise treadmill test, 24-hour Holter monitoring, all under the guidance of a cardio-oncologist. And as you can see from these figures, this is comparing baseline before the patient started drug to after at least a week exposure. There were no clinically significant changes in heart rate, blood pressure, or exercise duration with exposure to treatment. You can also see in the figure at the bottom that similar to what we saw with camizestrant, the rate of bradycardia does appear to increase with increased dose. And for that reason, the 30 milligram dose has been selected to move forward in evaluation. So let's now change to think about the mTOR PI3 kinase AKT pathway. This is a pathway that is frequently altered in hormone receptor positive breast cancer about 40% of the time and has a key role in endocrine resistance, thus making it a very attractive target for novel therapies. And at this point in time, we now have at least 3 therapies approved in this setting. We can think back 10 years ago to the initial data from the Bolero-2 study, which looked at the addition of the mTOR inhibitor everolimus to the backbone of exemestane, leading to approval of the drug. Once the drug was available in clinic, we all learned that there was a fair amount of stomatitis seen with this agent. This led to a prospective study called SWISH, which looked at prophylactic use of steroid mouthwash in patients starting everolimus. And we can see here that with the steroid mouthwash, there was a substantial reduction in the rate of stomatitis, including no further grade 3 and a doubling in patients who experienced no stomatitis at all. And this has become part of our standard practice to offer prophylactic steroid mouthwash when patients start this drug. The next agent we have approved in this pathway is the alpha-specific PI3 kinase inhibitor alpelisib. This drug was studied in the SOLAR-1 trial, and we can see here that the addition of alpelisib improved progression-free survival in patients whose tumors had a PIK3CA mutation, and that's led to approval for PIK3CA mutant breast cancer. The toxicity profile from SOLAR-1 is notable for, I'd say most notable for hyperglycemia, which occurred quite frequently, including about a third of patients who had grade 3 hyperglycemia. Other common toxicities included diarrhea and rash. So since the approval of this drug and the experience of it in clinic, there has been substantial work to try to find ways to make this particular drug more tolerable for patients. One of the first strategies was thinking about how to prevent rash, as that can be a toxicity that's not only quite bothersome, but can also take a long time to resolve. Some of the patients in SOLAR-1 did receive prophylactic anti-rash medication. It wasn't mandated in the study, but 86 patients in the study did receive it. And reassuringly, we see that with the use of the prophylactic antihistamine, there was, again, a substantial reduction in grade 3 toxicity, as well as a large increase in patients who had no rash at all. And so this also has become part of our standard practice when we initiate alpelisib in patients. There's also very strict guidance for how to monitor for the development of hyperglycemia, including assessing hemoglobin A1C and a fasting glucose at baseline, and monitoring very closely, like a weekly fasting glucose when patients begin therapy. Sometimes even using continuous glucose monitoring can be a helpful strategy. The trial did not include diabetic patients, and if we are treating diabetic patients with alpelisib, we have to have extreme caution in terms of monitoring for the development of hyperglycemia. Due to the prevalence of this toxicity, this led to another prophylactic study called Metallica, which was presented here at San Antonio last year. This study offered a prophylactic use of metformin. Patients began metformin at 1,000 milligrams twice a day for a week, and then they began alpelisib with fulvestrant. The trial enrolled 2 cohorts, one cohort who did not have diabetes and another cohort who had prediabetes. And results from this study were very reassuring, showing that the addition of the metformin significantly reduced grade 3-4 hyperglycemia, which you can see in dark orange on these pie charts. It's particularly notable in the bottom column, which is the prediabetes patients, where you can see a pretty dramatic reduction in grade 3-4 hyperglycemia. So it is a helpful strategy to consider when starting alpelisib. One might say, though, that 1,000 twice a day of metformin can lead to diarrhea. And so are we trading one toxicity for another? And I think that really remains to be worked out. But ultimately, how can we harness the power of PI3 kinase inhibition with improved tolerability? And the future may be mutant-specific PI3 kinase inhibitors. The reason why we have this problem with the alpha-specific inhibitors is they are inhibiting the mutant PI3 kinase in the tumor, but they're also inhibiting wild-type PI3 kinase in normal tissues, leading to off-target toxicity. The next generation mutant-specific inhibitors, some of which are listed here, target the mutant PI3 kinase in the tumor, but not the wild type. And I think we're excited to see more data from these agents to see if this will be our next pathway forward. Finally, the newest kid on the block is capivasertib, which is an oral AKT inhibitor studied in the Capitello 291 study. This was a study that enrolled pretreated patients randomized to capivasertib and fulvestrant versus placebo and fulvestrant. I want to point out just a couple things about the study schema. First of all, unlike SOLAR-1, this study did allow patients with diabetes, a hemoglobin A1C up to 8%, or patients with diabetes not requiring insulin. It's a little broader eligibility there. Additionally, capivasertib is dosed 400 milligrams twice a day, 4 days on and 3 days off. That's kind of an unusual dosing pattern for breast cancer drugs, but that does allow a little break so that any toxicity that's building up might wash away before the drug is started again. Primary results of Capitello 291 showed that the addition of the capivasertib improved progression-free survival in the overall and AKT pathway-altered populations. And as we are aware, this drug just was approved for the AKT-altered population about 2 weeks ago. And so it may be arriving at our clinics, at least in the United States, any day now. The side effect profile was notable for a few key side effects. Diarrhea was prominent with an all-grade rate of 72%, although lower rate of grade 3 diarrhea. Rash was also notable, and about 12% of patients, depending on how you define rash, had a grade 3 rash. Hyperglycemia, however, was less prevalent, occurring in just a fraction of patients. 35% of patients required a dose hold, 20% of patients required a dose reduction, and 13% required discontinuation of therapy. Just focusing on those key side effects of diarrhea, rash, and hyperglycemia, in general, these are side effects that happen early on. If we look at the median time to onset in days, for diarrhea, it's 8 days. For rash, it's 12 days. For hyperglycemia, 15 days. So again, toxicities occur early, and when we start patients on therapy, we want good communication and support to make sure that if a toxicity is beginning, we are aware of it and can modify as necessary. Hyperglycemia was more frequent in patients who had a history of diabetes or patients with an elevated BMI. Supportive medication use was prevalent in Capitello 291. Not every patient with diarrhea used an antidiarrheal, although you can see at least half the patients used a drug like loperamide. The majority of patients who experienced rash did use some sort of treatment, and I'll note that 20% of patients with rash used systemic steroids, which to me indicates that that was a pretty significant rash. There's less use of anti-hyperglycemic medications because that toxicity was somewhat lower. So if we put the two drugs side by side, alpelisib and capivasertib, we could say that there is somewhat more diarrhea with capivasertib all grade, although the rates of grade 3 diarrhea are fairly similar. The rates of rash are also fairly similar. More hyperglycemia seen with alpelisib than with capivasertib. Stomatitis as well is fairly similar. As I said, we're all going to be receiving, or at least in the U.S., this drug in our clinics in the next week, and so we have to think about how we're going to give this to patients. And at least right now, I don't think we have all of our prophylactic strategies in place. That's a little bit TBD. But I would say one could consider using prophylactic antihistamine like a cetirizine, which is a well-tolerated, non-sedating antihistamine to prevent rash, as we do with alpelisib. But whether we need to use any other prophylaxis is still to be determined. For example, steroid mouthwash, loperamide, glucose monitoring, metformin, and we would look forward to some data that helps guide those decisions. And then finally, I just want to consider all of these drugs that we're talking about are combined with endocrine therapy. Endocrine therapy has its own toxicity profile, as I think we're all aware. This can affect patients in the adjuvant setting and in the metastatic setting and may contribute in some way to the experience of receiving targeted therapies. These toxicities also can impact a patient's ability to take the medicine and be adherent with medicine. I think we're all aware that over time, rates of long-term adherence with oral antineoplastics declines. And if we look at patients taking adjuvant endocrine therapy, by year 4, it's estimated up to half of patients might have actually stopped taking their medication. There are multiple factors that affect adherence, and I would just point out, to echo what Antonio mentioned before about financial toxicity, how much a patient pays for a drug can impact whether or not they take it. And you can see from this figure that patients who paid less for their medicine were more adherent with it than patients who were asked to pay more. And particularly with these expensive targeted therapies, this is a very crucial factor. And when we think about a model of adherence and how we keep patients on therapy, I would really stress that side effects and toxicity plays a major role. So in conclusion, I think we're all thrilled to have many exciting agents for hormone receptor positive disease in both the advanced and the early stage settings, but progress can come with a price, as each of the agents has a specific toxicity profile. There are many maneuvers, including dose reductions, modifications, novel dose escalation, use of supportive or prophylactic medications that can improve the tolerability of drugs and maximize clinical benefit. But future drug development really requires agents that have the right balance of efficacy and tolerability to maximize our therapeutic index and help patients stay on effective therapies. So I thank you very much, and I'll look forward to your questions in a bit.
Erica, thank you very much for a great presentation. I think, as Drs. McArthur and Mayer just reminded us, things have gotten complicated. Some of you in the audience may remember that there was a time everything you needed to know about chemotherapy, if you knew AC and CMF, you were okay. All you needed to know about endocrine therapy, if you knew tamoxifen, you were okay. That was the reality in the late 80s and early 90s. And until recently, everything you needed to know about immunotherapy was trastuzumab. And I think things have gotten a little more complicated than that. And we are very fortunate today to have Dr. Doug Johnson. He is an associate professor at Vanderbilt University. I think he deserves an extra round of applause because he's a melanoma doctor. And he came here just to be with us. He had no other reason to be in San Antonio. So, Doug, really, we appreciate you making the extra effort. But also, I think we are going to be the ones benefiting from you being here, because obviously he has been using very successfully immunotherapy for much longer than we have in breast cancer. So we thought it was a special treat to have someone of his expertise to tell us about the good things and the bad things we can do to patients. Doug?
Well, thanks so much to the organizing committee, including Justin Balco, for the invitation. I'm really pleased to see claps instead of boos for someone who's not a breast cancer doctor. So thank you for the opportunity. I was also going to say there's many talented breast cancer clinicians and researchers at Vanderbilt, but I am not one of them, so we'll make do. So here are my other disclosures. So we'll talk a little bit today about immune-related adverse events in terms of thinking about them from a big picture standpoint. And then I think rather than regurgitate specific guidelines on this individual toxicity, you should get this exact treatment. Rather, I thought we'd talk about important considerations that really come up in everyday practice, when and how to use these checkpoint inhibitors most effectively, and how to deal with some of the toxicities. I also will not presume to tell you, when and where to use these checkpoint inhibitors. Clearly, there are many other people on the stage and in the audience who could opine much more eloquently on that, as far as when and which patients to select for use of pembrolizumab. So just to level set, this is very familiar to many of you in the audience, but just to quickly go over this, the mechanism of immune checkpoint inhibitors really relate to the T cell to the cancer microenvironment and the T cells present therein. So in inflamed tumors, there are many T cells present. They recognize the tumor. They're poised to eliminate the tumor, but something really important happens, and that's the interaction between PD-1 and PD-L1 shuts down the T cell, and prevents the T cell from eliminating the tumor. So if you can block that interaction either on the PD-1 side or on the PD-L1 side, you can then reinvigorate the T cell and hopefully allow it to eliminate the tumor. Now that's great when you're talking about the tumor microenvironment. You have T cells specific to the tumor. Not so great when you're talking about sites of inflammation, because in the physiologic setting, PD-1, PD-L1s mitigate inflammation and prevent autoimmunity. So when you remove those brakes, you can not only trigger inflammation against the tumor, you can also cause immune-related adverse events. Now, sorry, I noticed I had a typo here, but clearly there's a couple of indications, of course, for pembrolizumab or checkpoint inhibitors in triple-negative breast cancer. There's in the PD-L1 high metastatic setting, and then in PD-L1 agnostic in the neoadjuvant setting in combination with chemotherapy. And I better not say any more about breast cancer. So so we'll start with a case that really got us very interested in immune therapy and really demonstrates the potential real harm of immune-related adverse events. And this was a patient, a 63-year-old patient who was in our clinic, had just gotten started on ipilimumab and nivolumab for her widespread metastatic melanoma. And very early on treatment, just 12 days into therapy, she came into the emergency room with pretty nonspecific symptoms: shortness of breath, chest pain, a mild cough. And you don't have to be an emergency room physician or a cardiologist to realize that those are very concerning numbers, very elevated troponin and creatine kinase. And now this you might have to have a little bit more skill to look at. I'm not a cardiologist either, but if you can kind of squint and look at the bottom line, you can potentially see that the P waves are completely divorced from the QRS complexes here. And so that means that the atria and the ventricles are completely unsynchronized from an electrical standpoint. And this is something known as complete heart block. And this is a very unstable rhythm. And unfortunately, in this patient, deteriorated to this, which again is a very concerning rhythm of ventricular tachycardia. And this is really not something that's compatible with life. And so this depicts the patient's course, where the patient came in with shows their troponin levels over time. And as you can see, despite initially ruling out that the patient had a heart attack, and then with steroid administrations, despite that, the troponin levels continued to go up, and the arrhythmias continued to get worse. Unfortunately, within 4 days of admission, the patient had passed away. And so this was a case of immune checkpoint inhibitor-associated myocarditis, inflammation of the heart. And basically, we had another case that came in very similar to this about 2 weeks later, which I can tell you is quite disconcerting. And these patients had a really unique clinical course where they had these really fulminant arrhythmias, where they had a progressive heart block. The first patient actually came in with first-degree heart block, developed second-degree heart block, then third-degree heart block, then ventricular arrhythmia. Clearly a very alarming clinical course, to say the least. Notably, the patients, both, and in general, this has persisted, usually have preserved ejection fraction. So this is not, this is not heart failure. This is something different. Also, the patients often have associated myositis. So it's not just the heart muscle, but it's the skeletal muscle. And these patients tend to have very early onset events, sometimes just days to weeks after starting treatment, and a very high fatality rate. And so this depicts, I think, an interesting slide where we actually learned, unfortunately, a lot from the autopsy in this situation, where you can see in the black arrow, this is this slide from the patient's esophagus, and in the black arrow you can see the smooth muscle that is absolutely completely unaffected by the immune process, but in the bottom right corner you can see the skeletal muscle is absolutely obliterated by T cells, which really shows the specificity of the inflammation in this process. Well, thankfully, myocarditis doesn't happen very often, although certainly it's a really important consideration if it does happen. So what are the toxicities that we're likely to run into? Now, any of you who have treated patients certainly know this, but these list some of the most common ones. So hypothyroid, pneumonitis, hepatitis, colitis, arthritis, and rash. Those are the ones that we see most often. But unfortunately, there's a wide spectrum of other less common toxicities. In fact, I almost think of it is more like what organs are not affected. I think I've not seen prostate or uterus or ovary inflammation, but that's honestly probably just because they're a little more difficult to detect. Really, essentially any organ can become inflamed with immune checkpoint inhibitors. And this is some melanoma data. I'll go to breast cancer data in a second, but you can see that most patients, even treated with single agent PD-1, have some level of toxicity. And you can see more severe levels of toxicities requiring either discontinuation or high-grade toxicities are in the range of 5 to 20% for patients treated with anti-PD-1. And of course, that goes up with combination therapies, which is not as relevant now in the breast cancer world, but certainly may become so in the future. So here's some data from the triple-negative breast cancer study. And I would say in general, we tend to see roughly similar rates of toxicities across cancer types, similar from melanoma to lung cancer to breast cancer, et cetera. However, there are some slight differences. For example, lung cancer tends to get a bit more pneumonitis, melanoma tends to get more vitiligo. So there may be some slight associations with breast cancer that do come forward in the future. So just a couple of quick numbers to highlight. So at least in the metastatic setting, there are very few high-grade immune-related adverse events, only about 5%. And this may relate to a shorter duration of therapy in some patients. Difficult to say. We'll certainly be looking for more data over time. But one other thing to highlight is the high rate of hypothyroidism. So this is true for really across cancer types. And this is particularly relevant, as I'll talk about in a minute, because these hypothyroid events tend to be lifelong. So you're having about a 15% rate of lifelong hypothyroidism. Notably, there were also 2 deaths from toxicity, so 0.4%, which is really in line with a lot of other studies that have been done. And this is in the neoadjuvant setting, really kind of pretty similar data presented in a slightly different way. Again, about a 14% rate of hypothyroidism. Also call your attention, it's a little small, but at the bottom arrow, there's about a 2+% rate of adrenal insufficiency, which is also a lifelong toxicity, also worth thinking about in the neoadjuvant context. And again, about 0.4% fatal toxicity rate. So why do these happen? You know, clearly the simple answer is pretty easy, right? You're removing brakes on the T cell and you cause some inflammation. That seems pretty straightforward. However, it is very, very difficult to predict which patients will get toxicities. 2 patients can come in, look exactly the same, have similar history and so forth, and one may get multiple organs inflamed and the other patient will have absolutely no toxicity. So there's a number of there's quite a lot of research going on to try to tease out the mechanisms of this, and I won't go into too much detail, but some of the theories can include that there's some smoldering autoimmunity beforehand, so maybe you can detect that with circulating autoantibodies or other methods. There may be some cross-reactivity with the tumor, so maybe there's T cells that recognize both the tumor and normal antigens as well. But regardless of the mechanism, it remains very idiosyncratic on a patient level. We unfortunately don't have any sort of tests that we can determine, hey, you're going to have grade 3 colitis and you're going to be completely unaffected. This is seemingly random on a clinical level. Also seemingly difficult to predict is the timing. So certainly with many sorts of targeted therapies and chemotherapy and so forth, there's a little bit of a sense of when you can expect toxicities to occur and so forth. And there are some rough patterns with immune-related adverse events, but they're much more generalized. So you can kind of see in the graph that in the pink there, the skin toxicity tends to be very early, followed by colitis, and then followed by several others with later onset, including pneumonitis and nephritis when that happens. But really, these are generalizations, and on an individual patient level, again, really any toxicity can occur at really almost any time. So that the patterns can be a little bit helpful, but at the same time, it's very difficult to hang your hat on them. If a patient calls in with diarrhea, you can't, look up a chart and say, oh, this can't be colitis. It could be really almost any time, including up to 6 months after a patient stopped therapy. So that's also important to keep in mind. The pharmacodynamic half-life of these drugs is quite long. Okay, so how do we treat these? Again, I'll just very briefly cover the sort of general treatment paradigms and then get into more specific situations. So from a grade 1 standpoint, in terms of mild toxicities, we're really talking about supportive management. So, if it's a rash, you can give topical steroids. If there's a hormone deficiency like hypothyroidism, you can replace that. And then really you can continue anti-PD-1 and monitor the patient. You probably want to monitor them a bit more closely, of course, to make sure it doesn't escalate, but that's at that point. For more severe toxicities, the ones that are either meet certain criteria, which are there's a number of references, including the CTCAE being the primary one. For more persistent grade 2, you need to hold therapy. And of course, that's not enough because these therapies, again, have very long pharmacodynamic half-lives. If you just stop therapy, you're most likely not going to get improvement, at least not in any sort of reasonable clinical time frame. So steroids is really important to mitigate the inflammation. And really, the starting dose tends to be 1 milligram per kilogram or equivalent of prednisone, and then that's tapered over 4 to 6 weeks once the patient improves to grade 1 or better. And so steroids are really the cornerstone of management. And then we'll talk a little bit more in a minute about rechallenge, but usually if it's a more mild toxicity, you can consider rechallenge. If it's a very severe toxicity, life-threatening, or meets other certain criteria, which we'll talk about, you probably don't want to restart. And then if the patient's not getting better with steroids, there's a number of disease-specific agents. So for example, colitis, if it's not getting better with steroids or if it flares with the steroid taper, you can give infliximab, which of course is used for inflammatory bowel disease. And similarly for hepatitis, you can use mycophenolate. There's some that don't really have a great second-line option, but many do. And infliximab, mycophenolate being probably the most commonly used in the steroid refractory setting. And I should also note that this is not really evidence-based. So really none of these therapies have been rigorously tested in a randomized trial. They've of course been used in a randomized trial in the context of other checkpoint inhibitors, but they've really not been compared one steroid regime versus another. Steroids have never been compared to infliximab on a rigorous basis. So this is all, somewhat expert opinion. So why care about immune-related adverse events? Well, clearly, discontinuation of therapy is very important. With more aggressive regimens, that may be as high as a third of patients with single agent or anti-PD-1 plus chemo. You're probably talking lower numbers, but certainly discontinuation of therapy is very important. And as I mentioned earlier, fatal events it's a real consideration. Certainly, if you're talking about a fatal cancer with a 100% fatality rate, it's maybe a little bit less of an immediate consideration. But certainly, when you're talking about neoadjuvant or adjuvant therapy for a patient, if you have a 0.4% rate of fatalities, it's not to say you shouldn't use it, because clearly improved overall survival with therapies are really important too. But it's at least a consideration to think about when you're making your treatment decisions. And really, with single agent anti-PD-1, which you saw in the breast cancer data as well, it's about a 0.4% fatality risk. And what's also relevant is you can see the time to onset is pretty early. So those really severe fatal toxicities do tend to happen early when they are going to happen. So again, important consideration if somebody's otherwise healthy, they could potentially have those kinds of toxicities. Again, on a population level, these therapies do improve survival. So I'm certainly not saying they shouldn't be used. It's just an important consideration. And finally, chronic toxicity is also an important consideration when somebody's especially in the curative setting. We did a study in adjuvant melanoma where we basically saw about 40% of patients have some sort of chronic toxicity. Now, that doesn't mean lifelong. That just means that it was still persistent 3 to 6 months after stopping therapy. And we did notice some of the side effects got better, but certainly the endocrinopathies were very persistent. So hypothyroidism, adrenal insufficiency, rare cases of type 1 diabetes. And there were also worse symptomatic ones as well, including arthritis, neuropathies, and so forth. So again, a consideration for patients who are potentially curative, especially for low-risk patients. Okay, so we'll talk a little bit about important considerations of things you may come across in your practice. Just going over the data, going over the literature, and some experiences too. So the first one, we'll start with an easy one. So what kind of monitoring should we do for patients? So clearly, you want to ask patients what kind of symptoms they're having. Clearly, there's many times patients will minimize their symptoms and not talk about it for very understandable reasons. But of course, we want to know if a patient has severe diarrhea or other symptoms. And of course, we need CMP, CBC, and TSH with every cycle. The guidelines say you can get TSH every other cycle. I find that whenever you don't get it, you probably need it. Fatigue is such a common issue, and so you usually want that TSH. So I tend to get it every cycle. I don't see a real reason to not get it. And then, of course, other labs can be symptom-directed. The ones I probably reach for most often would be a random cortisol, which can give you a sense of at least a screen for adrenal insufficiency. Of course, it won't rule it out if it's in an intermediate range. You might need a quart stem, but certainly if it's less than 0.3 and the patient's had no other steroids, it can be diagnostic of adrenal insufficiency or hypophysitis. And then troponin and CK can be helpful too if patients have weakness or chest pain or other concerning symptoms for myocarditis or myositis. Number two, when to stop. So I've certainly seen, and this is very understandable, especially given the paradigms that we use other treatments, but in many cases, we do really have to treat the side effects aggressively, especially when you're getting into high-grade toxicities, because these can get worse and, of course, morph into fatal toxicities. I've certainly seen many patients that just continue therapy even despite 20 bowel movements a day for colitis and so forth. And so it's very important to really be be monitoring these side effects and potentially stop therapy and institute steroids. So, really for all grade 3, 4 toxicities, you want to be at least holding therapy, stopping therapy. And again, the CTCAE can give you a good reference for, it's always hard to remember sometimes what exactly is a grade 3 versus a grade 2, but those can be a good reference for you. And of course, SITC and NCCN and ASCO and even ESMO have guidelines as far as how to manage these. So a quick Google search will, really get you there. But on the other hand, it's also important not to stop if it's not necessary. And so I think the biggest one to really remember are the endocrinopathies. So even when the endocrinopathies happen, they're really important. They're obviously a big deal for patients, but there's really no benefit to stopping. So even if somebody gets adrenal insufficiency, even if someone gets type 1 diabetes, again, as big of a deal as that is, there's really unfortunately the ship has sailed. There's really no gland recovery with steroids or with any other kind of treatment. There's really no benefit to stopping. Of course, if the patient wants to stop, that's not unreasonable, but it's not going to help gland recovery or anything like that. So usually, at least the guidelines would say to continue therapy even with endocrinopathies. And of course, if there's toxicities that are not attributable to immune checkpoint inhibitors, of course, use clinical judgment, but that doesn't have to stop. So re-challenge is a big issue. So if somebody does have a toxicity, you give them steroids, they get better. What to do then? I think one of the first questions I always ask is, do you need to re-challenge? So is this patient progressing through therapy? Well, that's probably not somebody you want to take the risk of having the toxicities again. You're probably not going to benefit them. On the other hand, if you're you're almost done with your neoadjuvant regimen, you have 1 dose left, it's probably not worth giving that extra dose. These drugs have such a long half-life that 1 extra dose is probably not going to make any difference from the standpoint of anti-tumor outcome, and certainly it may have a real toxicity benefit. In fact, when I explain it to patients, I always say, hey, the benefit of 1 extra dose versus the risk of an extra 6 weeks of steroids, it really probably evens out, if not favors just going ahead and stopping. So I think that's the first question is, do you need to re-challenge? If you do re-challenge, there's basically a 50% risk. There's been a number of retrospective studies from countries, from multiple tumor types, multiple countries, and it's basically about 50-50. And again, there's not a great way of predicting one way or another. But so the way I tend to think about it is there are some factors that would push me towards re-challenge, and there'd be some factors that push me away. And so the ones that push you towards it are somewhat intuitive, but if a patient, sort of just barely meets that grade 3 threshold, they respond very quickly to steroids, well, you think you could probably salvage that patient pretty easily if they do have a recurrent toxicity. Also, if a patient clearly benefited from therapy and, relapse a year later, well, that may be a patient that if it's indicated, could benefit from treatment again. And then, of course, if there's unclear attribution, if you're not really sure it actually was from the checkpoint inhibitor, that might be a reason pushing you towards. Of course, on the other hand, there are factors against re-challenge too, which are somewhat the converse: very severe toxicity, steroid refractory issues. You don't think the cancer is really benefiting, and somebody's just come off steroids. You might consider waiting in some cases. So none of these are absolute, but I think they're reasonable rules of thumb to help you make your decision about when to re-challenge versus when not to. Unfortunately, we don't have great predictors of when it's going to happen, when it's not going to happen. It is about 50-50 in most cases. All right, what about low-grade immune-related adverse events that are important? They're impacting the quality of life of a patient, but in many cases, the physician doesn't want to stop treatment. The patient doesn't want to stop treatment. So what do you do? How do you help manage some of these side effects? Well, I just listed a few of the more common ones. So rash is, of course, a very common low-grade toxicity that can be very, very bothersome to patients. And so really the cornerstone of management there, certainly you can refer to dermatology for any tricks that they have, but topical steroids, triamcinolone especially, can be very helpful. Other topicals like moisturizing cream, oatmeal baths, et cetera, and antihistamines can be very helpful. There's also a phenotype of itching without rash. This can be actually very, very bothersome to patients. You look at the skin, there's nothing there, but the patient's quite itchy. This is probably more of a neurogenic itch, and so sometimes GABA agonists can be very helpful here. Pregabalin or gabapentin can be helpful. There's a number of other case reports of things like naloxone and so forth, so this is also maybe a time to refer to dermatology for these patients. Again, not terribly common, but pretty bothersome when it happens. Joint pain clearly can be an issue with checkpoint inhibitors, low-grade arthritis, and so again, rheumatology can be helpful. I oftentimes will manage these folks with low-dose prednisone. That doesn't seem to impact the response to checkpoint inhibitors. You obviously have to be careful with that because it can make people iatrogenically adrenally insufficient, so it's certainly a consideration there. And then there's sometimes DMARDs can be helpful, like hydroxychloroquine or methotrexate or something like that, to help manage the patient's joint pain and allow continuing therapy. And then, of course, fatigue, that's a big one. If any of you have any good suggestions, I'd love to take it. This is very challenging, of course. It's, we don't have great silver bullets for fatigue, and obviously it can be a real issue for patients. It's important to do a good lab workup, make sure they're not hypothyroid, make sure they're not adrenally insufficient. You, of course, don't want to miss that. But in many cases, it's just the drug itself, and so it's very hard to manage that other than, optimizing lifestyle kinds of things. So that can be a real challenge. Another really important consideration is, what about patients with pre-existing autoimmune disease? So at least one series showed that about 12% of patients with metastatic lung cancer have also pre-existing autoimmune disease. And so this is, of course, a really big question about what do you actually do when the patient comes in that has Crohn's disease or rheumatoid arthritis. And so there's been a number of retrospective studies, and really to boil down a bunch of studies, essentially they come down to that the patient will have an autoimmune disease flare if you give them anti-PD-1 therapy in about a quarter to a half of situations. And there's studies have differed in terms of which types of autoimmune diseases will flare and so forth. So it's very difficult to say if one has a higher risk than another. And then probably regular IRAEs have a slightly higher risk than the average patient, although not dramatically higher. So it's something that can be considered. So when you're actually making the decision, it's really a sitting down and having a risk-benefit discussion with the patient, knowing that there is a very high risk of them flaring. On the other hand, metastatic cancer or other cancer is quite severe too, so that's a real consideration as well. And then in many cases, you can potentially co-manage them with a rheumatologist or GI person and then optimize them. Now, you usually don't want heavy-duty biologics in combination with anti-PD-1. If you're giving a JAK inhibitor and pembrolizumab at the same time, you're probably blocking the same T cells that you're stimulating, and so it really probably doesn't make sense. So usually if somebody's sick enough to require a biologic, they probably don't need to have anti-PD-1 except maybe in extraordinary circumstances. And you may be able to get away with tweaking their immunosuppression in conjunction with their other physicians. And so the last couple of slides I'll go through quickly, but of course another important consideration is as these combination regimens proliferate, certainly including chemotherapy plus checkpoint inhibitors, it's oftentimes difficult to attribute what the toxicity is coming from. And so certainly time course can potentially be helpful in terms of holding chemo and the side effect gets better. Well, clearly you've got an answer there. On the other hand, if they respond quickly to steroids, there may be that may also give you an answer with checkpoint inhibitors. And in some cases, when you don't have, you're not sure, you can of course get a scope or something like that, some sort of diagnostic test that might help give you the answer. And so to that question, when do you give empiric steroids? I think that's an important consideration too. Many times patients will come in and you think it's checkpoint inhibitor toxicity, but you're not 100% sure. And there's always that consideration, do I wait for the GI to scope the patient? Do I give them empiric steroids? There's no clear-cut right answer, but I think the things that help guide me is, how sick is the patient? If they're sicker and more symptomatic, well, you're probably going to at least give them a trial of steroids. If it's more of a smoldering situation, perhaps they can wait and really try to get an answer rather than just empirically treat. So there's again not a clear-cut right answer. And then finally, other long-term impacts. So clearly, acute toxicities while patients are on therapy are really important. Chronic toxicities, as I think I've shown you, can be an issue for a subset of patients. And then we're still in the process of trying to understand what the impact is for other immune processes. So clearly, there's many pathophysiologic processes in the body, like atherosclerosis and others that are immune-mediated, and how do checkpoint inhibitors impact those? How do they impact antiviral immunity, et cetera? These kinds of questions are still being answered. So with that, thank you very much for your time and attention, and we will take any questions afterwards. Thanks.
Thank you very much, Dr. Johnson. And I actually want to thank all the speakers. I was The concern with a session like this is that you find yourself just going down a laundry list of toxicities and side effects, but I think we learned a lot of things that many of us who take care of patients or help patients in the clinic can take back to our clinical practices. We have a number of questions, but before we go on the questions, I actually would like to ask Ms. Sheila Johnson. She is an advocate. She's on the panel with us. Sheila has a wonderful website. If you can go there later, asurvivorslens.com, altogether, asurvivorslens.com. And Sheila, one thing you have on your website, 2 words as you go in. One is hope. The other one is resilience. And I think listening to these presentations, resilience has to be the biggest thing that patients have to deal with, not only the uncertainties and the fear of the diagnosis, but also deal, as I said at the beginning, with our best intentions. So, Sheila, I wanted to give you a chance to say a few words, things that you would like us to keep in mind and your reflection so far. It should be on if you start speaking.
Hello? Oh, okay. I'll get it right. So hi, I'm Sheila, and I've been living with metastatic breast cancer for 14 years now, which means that I've been living with it for 5,111 days. I always say thanks to research and my doctor is the reason why I'm still here. I'm also a 25-year Air Force veteran, so and advocacy has become a part of my second career, I guess. But back in 2009, I was diagnosed with metastatic breast cancer, and it has spread to my liver and ribs. And I've been throughout the but throughout the 14 years, I've been on many different types of chemo. And in 2018, I was on the Destiny Breast trial. I had a 4th progression in my ribs. It's my 4th rib. And my doctor recommended this trial for me. And it worked. It worked for 3.5 years, but the toxicity and the side effects were horrific. And I would sometimes have to go back to my doctor and tell her, like, I can't do this because this is, you know, it's the nausea, the fatigue, my quality of life was hampered. And now, because it's been, now it's in her too, of course, but I'm on a site for, Facebook site for, on Facebook for the drug, and patients are like, they're asking, should I stay on it? Because it's so toxic, the fatigue. And it's not only this drug, but there are so many drugs out there that it's just like, and it changes our quality of life. You know, we want to live longer, but we don't want our quality of life changed that much where we're scared to go outside, you know, because we don't know whether we're going to throw up or we're going to have diarrhea, you know. Just recently, I was on the Facebook page, and I'm part of another group, and they said, you know, I'm going to ask my doctor, because this drug gives me so many side effects, can I skip December? Because I want to have a great December. Well, why patients have to choose between their medicine and choose to have a nice December because of Christmas, you know? I think that doctors should listen to their patients to make sure that you're asking about the side effects. And luckily, my doctor, every visit, asks me about the side effects. And sometimes patients don't even know what a side effect is. So initially being diagnosed, you know, make sure your patients know what a side effect is of the drug. Also, we did, you know, it's a patient-led initiative, and it's called the Patient-Centered Dosing Initiative, where we asked, we did a survey, and 1,221 patients took the survey, and we asked them, 86% experienced at least one bad treatment-related side effect. 20% visited the ER, and 43% missed scheduled treatment. So just imagine if a doctor would have said, or their doctor would have said, can we reduce the dose? Or this would have probably alleviated them from going to see the emergency room, going to the emergency room, or even missing appointments, you know. So it's just all about listening to your patients like myself and making sure that patients understand. You know, I hear sometimes patients say, well, I'm not going to tell my doctor my side effect because guess what? They're going to take me off of it. So I'm not going to even tell them the side effect. But we need to make patients feel more comfortable and coming to doctors and say, hey, this is the side effect that I'm having. And no, it does not necessarily mean I'm going to take you off, but we can reduce the dose. So we just want doctors to just listen to us, you know, and just make sure that we're all on the same accord with our doctors about the side effects and the toxicity of these drugs. And two, you know, when we say a patient is tolerable, what do you mean tolerable? It might not be tolerable for me. So when we're talking to patients, or when doctors are talking to patients, you know, tolerable, I know we use it a lot, or doctors use it a lot, but still, it's not tolerable for me because I have patients on the same drug and they're saying, well, no, I'm not having any side effects for me. I'm over here puking on you know, it's not tolerable for me. So maybe we can come up with a different word, too, as far as when we're describing side effects as well.
Sheila, thank you very much. I think this reminds me how important it is. We all get very busy in the clinic, getting page and emails, and before walking into the room, it's almost as if we need to empty our minds, pause for a second, and remind ourselves, even though we have 15, 20 patients waiting for us that day, we have that one patient right there in front of us. I have a couple of questions. We have some online questions, but Erica, let me start with you, listening to Sheila talking about the issue of toxicities. There's a difference between receiving therapy in the adjuvant setting. It's almost like a sprint, 100-meter dash, which may feel like a 10K or a 10-mile run, versus patients with advanced disease, which becomes a marathon or an ultra-marathon. And a lot of the drugs we have, they were developed on the basis of maximum tolerated dose, MTD, not minimally effective dose. So talk a little bit your thoughts on permission. You show data on efficacy. Once you see efficacy, it's okay to reduce the dose, but also drug holidays, strategies to allow patients, work with patients to keep them going in the long run.
Yeah, thank you. And I love the ultramarathon analogy. I think that's very accurate. You know, there's so much we know from our clinical trials in terms of how drugs are dosed and the schedules, and the attempts made in trials to use dose modifications to help with tolerability. But, you know, there's a lot that we don't know about novel strategies. And, you know, actually think about the melanoma world where patients get drug and then they stop and they're monitored. And we don't really do that in breast cancer. We just keep drugs going continuously. And I think it'd be very interesting to think about how we can build in more structured holidays or breaks or monitoring times when people are doing really well, so that ultramarathon is not only effective, but that we could improve someone's quality of life, give them a good December, and make modifications that work well with a patient. And I also, you know, I think your words are so valid, particularly about patient-doctor communication, because our visits are quick, and we often are asking questions that may not be getting at what really needs to be discussed. And you know, I think that's just so important to share what's on people's minds.
Thank you. And we have microphones. I see some people coming to the microphones as well. Before we start with Dr. Hirschman, Doug, I have a question to you about the whole issue of duration of immune therapy. Why did we come up with 1 year of therapy in the adjuvant setting? And then for patients with advanced disease, so many stories of patients who may receive just a couple of doses, develop some toxicities, come off therapy, and the disease remains controlled. What's going on?
Yeah, that's a great question. I think the 1 year number is, I think, a round number, frankly. You know, they had to pick something, and so a year was seemed as good as any. You know, obviously it'd be great to have something more scientific, but you know, with a new therapy, and obviously we saw great results with it in the adjuvant setting in melanoma. So I think that stuck. So, but it's a great question. In melanoma, we have great data that if you have a negative PET scan, a complete metabolic response at a year, you can stop pretty safely. In lung cancer, there was data that suggested that you kind of needed to keep going on therapy, at least for patients. There was a study that randomized patients that had stable disease or partial response at a year to continue versus stop, and the patients who continued actually did better. So there may be some differences, and there's probably individual differences too. It may be that there's some sort of threshold as well. Somebody develops incredibly robust inflammation from 1 or 2 doses, and that's all that they need, whereas other people, it may be more of a slow burn where there's a response over time. So it's a very complex question, and certainly I think data will be important in each individual tumor type.
But as far as tissue or circulating markers, we are still in the dark ages?
Largely. I mean, there's certainly, some decent biomarkers, like certainly Justin Balco and I've worked on MHC class 2 in terms of predicting response, but in terms of like when to stop, not great. Circulating tumor DNA, there's a lot of interest in that, but it's certainly not been validated on a large scale. Negative PET scans, I think, is probably the closest we are. Complete metabolic response for these checkpoint inhibitors alone can be a pretty good marker to stop therapy. Now, when you throw chemo in the mix, I think all bets are off, unfortunately.
Great. Thank you. Let's go with some questions. Please introduce yourself, and Dawn, go for it.
Yeah. Dawn Hirschman, Columbia University. So I guess my question is, how much we want to start to really push back on the phase 1 dosing paradigm, because, as most people realize, we're only capturing toxicities during that first cycle that then dictate, escalation, and then the dosing that's then used for phase 2 and subsequently phase 3, and it doesn't really capture late effects. It pushes the dose up, and, all of the subsequent millions of dollars that then go into phase 3 trials are based on, those 13 patients that were in the phase 1 trial, and don't usually include things like patient-reported outcomes and late effects. And I guess, to the panel, especially as we get into complex drugs like antibody drug conjugates, where the dosing may not necessarily be based on that same type of escalation paradigm, how much we're really willing to push back and change that model for drug development.
Dawn, this is such a great question. We may have regulators in the room, someone from FDA, but I don't think they're going to come to the microphone. Maybe they will. But I think one could argue that they actually have the ability to require companies, as they are moving to phase 2 and 3 studies, to actually test, especially in the phase 2 phase, before definitive study, alternative schedules or alternative doses, exactly to address the issue, MTD versus MED. Thoughts from the panel on this? Erica?
Well, there is the Project Optimus plan through the FDA, which is requiring companies to more closely evaluate doses and explore lower doses before the trials move on to later phases. So I think that Dawn brings up a wonderful point, that the way we establish the sort of recommended phase 2 dose, honestly looks quite barbaric, and we need to have a lot more sophistication. Also thinking about this morning in the oral session, there was a preoperative neoadjuvant endocrine study looking at doses of camizestrant, thinking about how we can look at a pharmacodynamic marker in the preoperative setting. And we probably need to do more work looking at pharmacodynamic markers to really identify what is the dose that actually gives us the benefit, not the dose that gives us something just under the tolerability threshold.
We have... Do I see someone with crutches? Would that be? We have a regulator right there with crutches. Tatiana, do you want to say a word about this? And then we'll go for questions. So Dr. Prow spent a couple of hours in the emergency room yesterday with a sprained ankle, and she's on crutches today when she should be home watching us on video. So
Antonio was nice enough to come to the emergency room with me for several hours, which is why he knows that. So thanks for a great talk. I'm glad that Dawn Hirschman made the comment that she did about use of cycle 1 dose-limiting toxicities to define the maximum tolerated dose, because I really think it's a mistake that we're doing this with drugs that are now routinely chronically administered. At the time that we first defined how we were going to establish what was the maximum tolerated dose, it was common that patients would only be receiving a chemotherapy for a few cycles, and therefore what happened in the first 28 or 30 days, mattered a lot. I think that's very different when we've got patients staying on drugs for years. The one thing that I wanted to highlight, I know that Dr. Mayer has already mentioned Project Optimus, which is an FDA project led by my colleagues Marat Shah and Atik Rahman, that is encouraging companies to do more dose exploration and optimization before we get to the registration trials, and in particular to study randomized range of doses in phase 2. But I think that the other thing that other therapeutic areas do and oncology really does not do is sparse PK sampling in a broad range of patients. So they're really throughout the entire development program continuing to think about the relationship between dose and exposure and response, and we don't do a great job of that in oncology. I think because historically we were developing cytotoxics and the right dose was as much as you can give.
Thank you, Tatiana. So we have a couple of questions on the microphone. Please introduce yourself, and then after that we'll come to you. Go ahead, please.
My name is Naji El-Sagir from the American University of Beirut, Lebanon. My question to Dr. Johnson, who gave us very nice practical talk. With a small background, we treat a lot of young women with breast cancer with a curative intent, and we give them, as you know now, neoadjuvant immunotherapy. Many of us are concerned about gonadal toxicity and ovarian function toxicity. We try to do, before we give them the treatment, cryopreservation, and even we may give them LHRH analogs. But what is your experience? Anything new about gonadal or ovarian function toxicities, and any ways to prevent that?
Yeah, it's a great question. There's very little data on that, unfortunately, at this point. There's been some case reports on mostly in men, obviously very different situation, but that did show some vas deferens inflammation, so it did raise concern that there could be, various different types of inflammatory toxicities in the reproductive tract. That has not borne out clinically to this point. I've had certainly plenty of patients who have gotten pregnant after immune checkpoint inhibitors, so there's not an obvious, in every patient effect, but it certainly needs to be studied. And clearly, the patients who have hormone-related changes, that can certainly be relevant from adrenal insufficiency or hypothyroid. So unfortunately, I don't have a great answer for you.
Thank you. Next question.
This is Jyoti Bajpai from Mumbai, India, Tata Memorial Center. I'm a medical oncologist, and apart from breast, I treat melanoma as well. So my question is regarding the immune-related side effects, and especially, while patient, they are responding at times, they develop certain side effects, skin-related, like vitiligo in melanoma patients more commonly than others, which is actually not a toxicity, rather it's an indicator for a response, but it is cosmetically disfiguring and very concerning to the patients. So what should be done about, those kind of side effects?
Yeah, can you repeat what kind of side effects? I missed that, I'm sorry.
Vitiligo.
Right, yeah, so vitiligo is certainly a marker of response. We do see it more in melanoma. You do see it in other cancer types sometimes. It is a marker of robust response. Unfortunately, there's not much to do about it. It's something that it is a marker, a harbinger of good good response, but there's no data that steroids or anything have helped. I think most people have been reticent to use things like steroids because you would, worrying about blunting an ongoing response. So at this point, it's mostly just supportive care and sunblock and so forth. So it obviously does have cosmetic ramifications, but there's not much to do to prevent it.
Thank you. Martine?
Yes, Martine Picard, Brussels, Belgium. I belong to a relatively old generation of medical oncologists who have been taught that it's very important to keep dose intensity of cytotoxic drugs in the adjuvant setting, and there have been many publications showing that patients who do not get the optimal dose intensity have a worse outcome. For the CDK4/6 inhibitors, we hear a completely different story. So if you cannot take the maximum dose and you have a reduction in dose, you have similar outcomes. And I'm puzzled by this. So I'm just wondering, are we recommending the right doses, or could these patients do as well with reduced doses? And for ribo, it's already clear that 400 milligram works in early breast cancer, and the dose in metastatic disease is 600. So I'm getting confused here. I don't know if you have some thoughts.
I think that's a great question and observation. And I think that, again, raises the issue of how do we select the dose to move forward in studies? And is the dose that was selected the optimal dose for efficacy and tolerability, or was it just the dose that was the most tolerable of the doses that were effective? I think it's quite striking that in both the metastatic setting and in the adjuvant setting, honestly, for all three agents, we see equivalent efficacy at all of the available dose levels. And so it really does raise this question of perhaps a different dose could have been used to move forward in registration studies in both settings. I think it was great that ribociclib was moved forward in the adjuvant setting at a different dose. And I do acknowledge that the development of the oral SERDs is being more thoughtful about how dose is selected as those agents are also moving into the adjuvant space.
Great, thank you. In the middle, please.
Well, thank you, but most of my questions have already been answered. Actually, most of my questions
tell
have
us
already
who you
been
are.
asked. My name is Ellen Landsberger. I'm a patient advocate. So I'm coming up with a couple of tweaks to my questions. One, Dr. Mayer, thank you. Well, thank all of you for the very thoughtful comments and discussion. So following up with what the woman just asked, why not lower the dose for something like abemaciclib? Why not lower the dose for palbociclib so that maybe people can have higher white counts, et cetera? How do we change what's going on currently? And the second question I would ask has to do with patient-reported outcomes, of using more PROs. We keep hearing the PRO is collected, but it'll be reported later. And by the time it's reported in a secondary journal. There's no attention to it, and many, particularly community doctors, may not know about that stuff. So I would encourage, incorporating the PROs earlier into the publications.
Thank you.
Yeah, I mean, I think that the dosing for CDK4/6 inhibitors, as we've learned, there's a whole range of doses that are effective in terms of clinical cancer care. The drugs are approved at a starting dose, and our tendency is to use the FDA-approved dose and then modify from that. I'm hoping that our adjuvant trade study will show that perhaps, as I like to think about it, wading into the water as you start these therapies might make it a more tolerable experience than just jumping straight in. And, I'd say on the flip side that although we have many patients who may experience a side effect, there are also a lot of people who don't and who feel quite well at the FDA dose or with a dose reduction. So there's a whole spectrum of experiences. I'm so glad you brought up the topic of patient-reported outcomes, because it's really important. And I think we struggle because the instruments used to measure quality of life, like the typical instruments we use, are very blunt, and they're really not very sensitive. And we have seen multiple presentations where we see no difference in quality of life between arms, even though we definitely see toxicities. And I think, as you say, presenting and publishing PROs sooner and really highlighting what is the patient experience like, because that's much more sensitive and nuanced than our typical quality of life instrument that we use broadly across all trials.
We are coming to the end, but I want to do justice. We have a number of very nice questions online, so let's do a couple of rapid fires. I have 4 questions that came that I think I would like the panel to address. One actually is to Doug Johnson from Melissa McShane. In patients receiving neoadjuvant Keynote 522, so 4 chemotherapies, a course of pembrolizumab, should we do preoperative cortisol? These patients are going to go to surgery after receiving neoadjuvant pembro chemo. Should we do pre-op cortisol to rule out adrenal insufficiency? And what to do with the fact that all these patients have received dexamethasone for nausea management? Does it imply that we need to do a cortisol stimulation test?
Yeah, I think it's a great question. There there are varying practices. I think it's reasonable to do it. We don't really do it for our melanoma patients, but maybe we should. We certainly, at least for a checkpoint inhibitor alone, we tend to see pretty obvious symptoms when we see it. And so, we have a very low threshold to check it, but I do think it's certainly not a bad idea. You, of course, want to be very careful and not check it right after steroids have been given, so you don't fool yourself into getting it, but that would be a not too rapid answer.
My final question is going to be back to Dr. Prow or someone back from the FDA, so I'll give you 30 seconds, Tatiana, to walk back, to limp back to the microphone. So the second question is for Erica. So in terms of, this is from Daniel Morgenstern, what about patients with ethnic, or if that's a better term, neutropenia, or what to do with patients who happen to have low blood counts, low white counts to begin with, and challenges of giving CDK4/6 inhibitors?
So, we're just learning more about the spectrum of experiences of receiving CDK4/6 inhibition based on racial or ethnic background. We do know patients of Asian background tend to have more neutropenia on CDK4/6 inhibitors than others. But it's a topic that really needs to be explored more, and a plug that tomorrow we have a poster looking at race and ethnicity in Palace that will be in the poster session.
And the second last question, back to you, Doug. I think the answer is no, but this is from Hiba Tamim. Is there value in doing baseline echocardiogram, troponin levels, EKGs before starting therapy?
I think echo may be a little bit overkill. There's certainly some practices that do baseline troponins and EKGs just to have a baseline. We usually don't do it for single agent PD-1. For Ipi/Nivo, where you have a higher incidence, we do it. So there would be varying opinions. You could argue about it for a while, but we don't for single agent.
Okay. And the last question, I guess, goes to Dr. Prow. Again, pushing the FDA. This is actually a question from Doug E. And he's asking, should every new drug approval, should the companies, when they're doing their randomized trials, number one, should PROs be mandatory? And number two, should patient-reported outcome data be considered as in addition to efficacy data?
It's a great question. Great question. Anyone who knows me knows that I'm a regulator and a clinician, but I am a patient advocate above all, because what we are doing here is taking care of people. So the patient experience matters a lot to me. I think one of the challenges that I see as a regulator is that oftentimes the PRO work is not done with the same level of rigor as the other endpoints. And so I think if we're going to think about, for example, putting that information in the label, it needs to be done with the same rigor as other endpoints, which means you need to be very thoughtful about the endpoints. You need to be very thoughtful about the analysis. Ideally, you have alpha allocated to things that are important to you, where you want to make a labeling claim, and that is something that is extremely rare in oncology. We don't see many PROs where you have alpha allocated to an endpoint, for example. So that's one of the challenges. And I think if you have a situation where industry expects that maybe the data won't end up in the label, which is going to be the basis of their advertising, of course, then maybe there's not as much effort invested there as there should be. I do think that it's very important, and I'm glad to see things like pro-CTCAE, which allow us to have patient-reported toxicity data, because it's clear to me that clinicians underestimate the incidence and severity of toxicity a lot, and they've been the mouthpiece for patients in trials.
The only point that I could see some people pushing back a little bit is that the companies, by nature, they will have consultations with FDA at the end of phase 2 as they're planning for the phase 3. It could be that in your mandate, and you guys operate based on what Congress allows you to do to a degree, even though all of you are clinicians as well, is that maybe in your guidance, you can tell companies these are the criteria in your study design, in your analysis plan for the efficacy endpoint that need to be there. Maybe there is room for that to be included as well as the tools as for patient-reported outcomes do get better and become more standardized.
That's a great point, and I think one of the challenges that we have is, other than some very recently developed tools, most of the tools that we've used for patient-reported outcomes were still developed mostly by clinicians. They're not really developed by the actual end users and truly patient reported. So maybe that's the first step, is you need to have patients at the table as you develop better tools.
Great. This was actually so much better than I had anticipated. I was initially pessimistic that this was going to be a laundry list, but this was very cool. And kudos to all of you who have resilience and show resilience and stayed until the end. We had a full room until almost the end. So thank you very much. Thank you for the panel. This was great.